Welcome to Own Your Heart Health. I'm Dr. Regina Druz, your holistic cardiologist. This week, we will dive into common heart health concerns, uncovering root causes, and unpacking scientific discoveries and controversies. The information provided does not constitute medical advice. Please contact your healthcare practitioner before making any changes that may impact your health. Welcome, everybody. Today on the show, I have a very special treat. It's a great friend of mine, someone who worked with me shoulder to shoulder, or maybe computer click to computer click, as we were trying to put together our multi-specialty team for one of the very large organizations that serves senior patients. So please welcome Dr. Nina Maouelainin. Hopefully I did not butcher up the name. I really practiced. I really tried. And so Dr. Nina is a pulmonologist, but she's not just any pulmonologist. She's actually interventional pulmonologist, and she runs her own practice called Lung Health Services, as well as an educational foundation called Dr. Nina Lung Health Foundation. Welcome, Nina.
Thank you. It's a pleasure to be here. I am very excited for a very stimulating conversation and looking forward to sharing my thoughts, discovering yours, and sharing with the world what we can do better to protect ourselves and our lung health.
I agree. And, November happens to be, as you told me, it's the Lung Health Month.
Correct. November is Lung Cancer Awareness Month and COPD Awareness Month. It is a topic that is very dear to me. And unfortunately, lung cancer is still the number one killer in men and women worldwide against all other cancers combined. So it is a very crucial topic to discuss. And what better month to do it other than just the Lung Cancer Awareness Month?
Exactly. And so, it's interesting. I was always thinking kind of, what is going on, right? Because we are seeing progressively younger and younger patients, adults, coming down with cancer diagnoses. And actually, one of very close friends of mine who always thought that her issue will be cardiac because of the family history had cardiac CT when she was in her early 50s. And there wasn't any cardiac issues, but they found, as they say, a little something, something. And that little something, something actually turned out to be lung cancer, adenocarcinoma. And this is someone who never smoked in their entire lifetime. Could she possibly been exposed to secondhand smoke? We don't know what we're exposed to as children, but as far as she knows in her adult life, there were actually no exposures. So what is going on in your opinion? Because we're seeing fairly young people having a lot of subclinical heart disease, and also we're seeing this progressive sort of reversal of the age paradigm for cancer, because typically cancer is associated with older patients, maybe patients had certain exposures, but we are actually seeing things which are different. So what is going on in the lung cancer arena that you can tell us about?
So it is really a fascinating and sad situation because in the beginning, lung cancer had a direct correlation with smoking. So the more people smoked, the more likely they developed lung cancer. And small cell was very common. But as time went by, specifically lately, and really what was brought up to the forefront was with the NLST and the Nelson study that was presented at the WCLC, where they ended up really screening in Taiwan the full population to look for lung carcinoma. And unfortunately, the bomb that was delivered at that WCLC, I remember in Canada, was that the majority of the population that was screened, although did not have lung cancer, still 3.8% of that population turned out to have a stage 1 adenocarcinoma. What was even more shocking.
Let me ask you a question. So these were people who never smoked, right? They were non-smokers.
They just actually screened the whole population. And
then
they looked
population.
Because Taiwan was pretty small, and they found that around 3% of the population had a stage 1 lung adenocarcinoma. So they went and dissected the data And they noticed that close to 60% of the ones that were diagnosed with lung carcinoma were non-smokers.
Wow.
And
So the population, even though the overall prevalence was fairly small, was about just 4% or so. In that group of people, majority, 60%, never smoked. Have
correct.
they? So what was the investigators' sort of thought process as to why they are found? First of all, how did they even find lung cancer? How was the screening done?
So the screening was done by completing low-dose CAT scans on the population. It's very simple, which is now recommended in the United States for anybody that has a 20-pack year between age 50 and 77, which was a change because originally it used to be 30-pack years, 55 to 70. So that has changed now, and we decreased the amount of pack years to 20 pack years because the original study that was done in the VA was really targeting a typical average white male in the VA, and then many with low socioeconomic that really started smoking a lot earlier. African American, Hispanics were not really captured in that range. So that pushed the criteria to be changed to a 20 pack year. And that allowed us to diagnose many more that wouldn't have been included otherwise. So to go back to the Taiwan study, what was absolutely striking is that among the 60% that had lung carcinoma, non-smoker lung carcinoma, close to 80, if not 90% were female.
Interesting. So why is this happening more in women versus men?
Men. So they went back and they interviewed. Of course, there was a risk factor of lung cancer in the family, but more importantly, and it was added as a screening criteria now in Taiwan, is the cooking habits. Were they using? Yes. What type of fumes were they exposed to? Were they deep frying? How much protection they had inside the home whenever they were in the kitchen? And that brought up a whole other slew of questions about lifestyle. Fast forwards to expanding this type of screening to first world countries and European countries in Sweden, in Germany. And we're realizing that the oncologists on a day-to-day basis, when they look at their schedule, patients that they're seeing are less than 50 years old. And the majority of them are females. Actually, it's so striking. Today, they launched the Hear Her campaign at the Flores lab, which is specifically starting to recruit young female, pregnant, newly diagnosed with lung carcinoma with no risk factors.
Hi, everyone. It's Dr. Regina here. I know there are contradictory opinions about nutrition for heart health and longevity. Discussion often gets heated and confusing. There are those who push for low fat, low cholesterol. Then there are fans of a ketogenic diet. There are many anti-meat voices as well, suggesting vegan or vegetarian style of eating. With all the chatter out there on what and how to eat, my team and I decided to create a tool for patients, medical professionals to clear the clutter. It is called Holistic Heart University, and it provides on-demand courses, nutrition and lifestyle resources, information on supplements to make it easier to understand how to make healthy choices for your heart. I'm especially proud of our open office hours for program patients and the Q&A feature where you get to ask your individual questions and put us in the hot seat. Head out to the show notes for the link and use my special promo code to get a huge 20% off on our annual health and wellness subscription. The code is owner20, and I'll see you in the office hours. So, in March, obviously, I'm an integrative cardiologist and part of the integrative practice, and I practice with a lot of functional medicine in mind, right? So the practice patterns that I use are very much informed by the functional medicine approach. And, we always look at the systems biology and, of course, the process of detox and elimination and the toxic exposures plays tremendous role. So I was shocked, as a lot of other people were, when in March of this year, the study came out in the New England Journal of Medicine, where the group in Italy actually looked at the composition of the plaques that came out from patients' carotid arteries, right? So patients had blockages in the carotid arteries. They were qualified for surgery. They went, the surgery was done. And so the investigators then took those plaques and they studied them with a variety of different techniques, including look under the microscope and all sorts of chemical processing. And what they figured out is that there was a proportion of patients who actually had microplastics and nanoplastics, so teeny tiny particulate, plastics particles that were present in those carotid artery plaques. And when they went back and they looked at, well, what actually was happening to these patients, they followed them for quite significant period of time. And they looked at the incidence of myocardial infarction or dying from heart disease or just dying, period. So they figured out that the patients who demonstrated those plastic components in their carotid arteries had about almost a five times the number of cardiovascular events and were twice as likely to die from anything.
That is absolutely insane, because when you think about it, the amount of plastics that we have around us day-to-day basis, from the water bottle to the actual product that are disposable that we end up using, all of them are made out of plastics. The amount of people that microwave their food inside plastic containers, when you look at the actual not fruits, but vegetables that are already pre-made, all you have to do is toss the bag in the microwave. Don't open it, leave it sealed. It's plastic. And even when you go get a coffee, I mean, at this point, not to scare anybody, but when you look at the insulation inside your cups, when you go to the Starbucks or the Dunkin' Donuts, etc., the lining on the inside that allows the actual drink to remain warm, there is some plastic in it. So we're consuming so much plastic, but we're also inhaling it. And it was established that pretty much the exposure to microplastics end up interfering with the biophysical function of the pulmonary surfactants at the level of the lungs. So we have seen an increase in interstitial lung disease, which ultimately leads to hypoxemia. But how does that happen? Is because the alveolar structure, those balloons at the end of the windpipe, and the airway barrier function is completely disrupted by these deposits of microplastic at the lung epithelial.
So this is fascinating, but let me backtrack so that we don't aggravate our listeners with a little bit of a doctor speak. So we'll have to try to actually explain things so that everyone can understand. So surfactant, what is it? Where does it live in the lungs? And what does it do?
So surfactants, to make it simple, and the way I explain it in lame languages, when you look at your lungs, the lungs are trees. Just think about it. It's not two big balloons on each side with a windpipe in the middle. It's literally an upside down tree. Main windpipe comes down, goes to the right and to the left, and that tree with branches and roots going all the way out is really containing hollow windpipes. At the end of each of these little teeny tiny branches, you have, imagine a clump of grapes. Take the fruit out, you just have the skin left, and that's connected to the actual windpipe. So every single time you breathe in, the little grapes inflate and then deflate.
They're like little sacs, right? And we call them alveoli. Those little sacs, they're sort of dynamic. They become a little bigger and a little smaller.
And that's a whole other story when we talk about the pressure variation inside the lung and outside the lung that actually causes these balloons to inflate. But to get back to these little sacs, they're covered with blood vessels. Because when you look at the heart, as you are probably better at explaining it to me, the heart has two sides, a right and a left. The right collects the blood. When the right squeezes, it sends the blood to the lungs parallel to all these branches, and they end up around these little balloons. And around these little balloons, it sucks the oxygen that's inside the balloons, and then it carries all that blood back to the left side of the heart. And then the left side squeezes and distribute the blood to the rest of the body. So
so So that's where, and that's obviously cardiopulmonary, and that's, the essence of life. And if we didn't take a breath, we wouldn't be alive. So we have to take our breath. And so what is then a surfactant, and how does it actually trap those microplastics inside the little grapes, right? Those little sacs that would
Correct.
depend on them for the air exchange and for delivering oxygen into our blood.
So the surfactant is a product that, because as you can imagine, those little pockets end up having cells that lines the actual inside. And these cells produce this product because think about it. If you have a birthday balloon, to open up that birthday balloon, you always have that pressure that you have to overcome. So at the beginning, it's very hard to inflate. And then it
Resistance, yep.
and then once it starts inflating, it stays inflated all the way through. And it's much easier to deflate and inflate as long as it doesn't deflate completely. Otherwise, you're going to have to start all over again. But just think about the surfactant at this product that allow that elasticity and smoothness to keep these balloons open. So it's not sticky. It's not hard. It's very smooth and malleable. And anything, mucus included, viruses, bacteria that can disrupt that surfactant will make it much harder for the oxygen to float in. Balloons become hard, stiff. They don't stretch as much. You have deposits in there. And in general, you tend to feel heavy and you can't really breathe in as well as you should.
So imagine, so that issue then is that, going back to the study from Taiwan, because this is sort of mind-blowing that the incidence was higher in women, and the incidence was specifically higher because of the cooking techniques that they're using.
Right.
So is it that, we know, for example, certain types of cookwares to be avoided? Obviously, plastics are one of them. There is a lot of literature that says that, Teflon coated cookware probably isn't the best for people because of this plastic phenomena. So can we actually say that, was it because of the cookware that they were using, or was it, just the fact that there were so much smoke and so many toxic compounds that smoke actually consists of, were they wood burning, sort of like what should people try to avoid? I mean, we obviously cook in the United States, maybe we just don't cook the same way they do in Taiwan, but what would be useful for people to know to avoid actually trying to lower this level of exposure?
So the cooking, they actually developed what we call a cooking index. And that's a cooking index that they calculated based on the exposure to oil fume. And I realized as I started talking to my patients, specifically the one that were diagnosed with adenocarcinoma without any history, I asked them just randomly and anecdotically, what type of cooking do you do? Not everybody fries their foods, but few do. So the next question was, what type of oil do you use? Well, the oil that's in the market, you just go and grab oil. I'm like, do you look at the oil quality and type? Do you pay attention to the type of oils? Because certain ones are specifically for salads. Others are for high heat. And I was really surprised that people had no idea what I was talking about. So just imagine cooking or using oil to cook without realizing that certain oils cannot be used in high heat. Imagine the amount of toxins they end up breathing in, and worst, the amount of toxins if they recycle that oil. Yes. So when you get the Chinese food, when you go into those small, really restaurants in the corner, when you see the carts, the oils are recycled over and over again. And it's a small contained environment. And they're literally having such a high fume exposure that they are breathing in carcinogenic products. And that ultimately will impact it, is like being exposed to a chemical plant with benzos, or God forbid with asbestos or radon, which is a whole other topic that we can talk about. So the cooking index is really what we should be aware of. And what I always recommend is when people cook, avoid frying, period. If you use coal, make sure you have a very well aerated area and you're not exposed to inhaling all those products. Whenever you spray with PAM, please be careful, specifically if it's high heat outside. And it's such an easy thing to do now. Everybody's buying PAM or olive oil spray.
I don't use that because I use extra virgin olive oil, since I'm a cardiologist, and, extra virgin olive oil has usually very high temperature type of a set point. So, so it gets warm, but it doesn't really, generate a lot of these compounds. And, sometimes if you need to brown something, you can add a touch of butter, which is actually much less toxic than a lot of the plant-based oils. And, we also certainly have patients, for example, who don't necessarily know that they're getting an excess of omega-6 free fatty acids, which are pro-inflammatory free fatty acids. And some of the patients don't know that they have genetic variability that actually makes them more vulnerable to exposure to those omega-6 free fatty acids. And, of course, this is testable, and we test pretty much all of our patients for that. But this is fascinating. So were they able then in the Taiwan study sort of pinpoint a specific oil? What were these cooking habits, or was it more just, because they were frying so much and there was a lot of fried food?
It's fume exposure and frying food and oil fume that was the correlating factor leading to a higher risk. And that was common in these patients. And the risk was much higher if they had a family history of lung carcinoma, if mom or dad, whether they were smokers or not. Of course, secondhand smoking was also taken into account. So that helped really set the tone for us in the rest of the world to actually taking a look and studying and looking at the population that we have and how many of the lung cancer carcinoma that we're diagnosing are actually non-smokers. And believe it or not, 53% of them are non-smokers. So clearly, we have a high risk or higher risk than the Talent study, than what we compared it to previously in developing lung cancer in non-smokers. And I think it is probably not only related to the passive smoking exposure that we have, the cooking index score that probably is higher based on the socioeconomic index of the people that end up having the adenocarcinoma, but also cooking without ventilations, and more importantly, having a family history all the way up to the 3rd degree. Unfortunately, we don't screen for lung cancers in female. And what I always try to really reiterate to the general population is please advocate for yourself, specifically women. What are the chances that a 32-year-old female suffering from a dry cough goes to her primary and said, this cough is annoying, it's not going away, that she would automatically get a screening scan? Probably not. They will say it's postnasal drip. It's probably GERD, your allergies. And she will have the runaround. And generally, they're mothers, they're busy, life happens. If they don't ask for that x-ray, if they don't ask for their CAT scan, specifically if it is a small lesion, even if it is a 2 centimeter or 3 centimeter lesion, you might not see it on x-ray, depending on where it's located. And that's the story that we're hearing over and over again.
From multiple patients.
Young Lung Cancer Initiative is a nonprofit organization that is absolutely amazing in bringing to the forefront the young lung cancer patients that we have in this country. And they're raising the alarm. And women are suffering more than we realize in the United States. And I think we definitely need to have a game plan, as we did for the smoker. And by the way, just between parentheses, low-dose CT screening, although now approved, how many of them end up having the actual screening? Less than 10%.
Hi, everyone. It's Dr. Regina here. Many of my colleagues and I are noticing patients coming to us with self-ordered blood tests. When this trend started to gain momentum, I thought it would benefit many patients. After all, who doesn't want more access to health testing? However, I see that self-ordered labs often lead to more confusion and frustration for our patients. Patients are coming in with a pile of labs, and sadly, they're not better off for it. This is why we at Holistic Heart Centers have launched Heartwell Toolkits, a curated collection of blood and genetic markers that one can get at home, focused on heart and brain health, gives you all the data you need to make informed and actionable health decisions. The toolkits can be ordered at our shop on holisticcartcenters.com. You can find the link in the show notes. Use the code TESTING10 to get 10% off and free shipping. Couple of questions here. First of all, when you say it's approved, does it mean that Medicare and most insurance plans actually cover it? That's the first question I have. And the second question, where does one find this cooking index? Is it something that, let's say, is online and you can just go and plug things in and sort of see where things, end up for you? How does one size up, their possible risk of developing lung cancer, being a non-smoker, and being relatively young, which is what seems to be really on the rise. Very troubling trend, and I think it parallels the trend that we're seeing with colon cancer, and we're seeing this trend with breast cancer as well. That I have a very good friend who is an oncologist, specializes in colon cancer, and they are progressively seeing younger and younger patients who don't have any other risk factors. So where's that cooking index, and some sort of, what should a person do if they have reasonable concern that, they want to be screened?
So the first one, to answer your question with regard to the low-dose CT scan, the low-dose CT scan is approved by Medicare. Of course, the bureaucracy and the red tape is the most challenging part, because you have to justify ordering that low-dose CT. But the Medicare population does not need a pre-authorization and can have a CAT scan, a screening CAT scan, as long as the physician documents or the caregiver documents the actual risk factors and the criteria being met. 50 to
and
70.
that's how we get referrals for cardiac CT, because they do low dose CT. They see calcification in the aorta, and they send to us then for multi-slice detector cardiac CT.
That's exactly it. And the same thing is true. The opposite is true. We have a lot of people that are very proactive about getting their cardiac, their calcium scoring scans, or their PET CTs now for cardiac, performed by cardiologists, and then automatically something lights up, or they see something that's abnormal and they refer them back for a dedicated CT to be seen by interventional pulmonologist.
That's how my friend found out, her tiny little tumor.
Incidental finding.
Finding. It was excised, and she's fine. But if she didn't have the cardiac CT, she would not have discovered it.
And that's exactly it. So by Medicare, yes, it is covered. Not a problem. Now, with regards to private insurance, that's a whole different ballgame. Because, and I mean, if you recall the challenges to get mammography approved early on, and that's why the pink ribbon campaigns went crazy to increase awareness. My hope is that we will have the white ribbon revolution. And the white ribbon project is another one that was initiated by a non-smoking female who struggled, husband a physician, struggled to be able to get a CAT scan and to get a biopsy to ultimately find out that she had adenocarcinoma. And now you can see it's probably around LinkedIn and all different news media. It's a white ribbon made out of wood that says lung cancer awareness. But unfortunately, it is a struggle. Certain insurances do not approve necessarily that CAT scan unless there is really a push by the ordering physician or APP to actually challenge them, explain there's a family history, there is a high cooking index, there is a past medical history, and then obtain an authorization to get it done. It is unfortunate that we don't really have a game plan for non-smokers. And I think we're going to have to do something about it, because with the current screening guidelines, honestly, we miss 30 to 50% of the population, even in smokers. But we have zero strategy for new risk factors that were identified by the talent study. So we absolutely have to get back to drawing board. But for the people in general from home to try to do something to answer the question about the cooking index, there's no way to really calculate a cooking index. The way they measured it is by determining the amount of deep frying dishes that the person cooked per week, the amount of days, size of the actual dishes and whether or not they recycled the oil, what type of oil they used, and whether it was in a closed environment with a good ventilation system or not. And that gave them an idea of what the cooking index was. What we
I
can
see.
do what we can do outside of the cooking index, though, is look at our homes, because we might not be frying food as much as in the Asian countries, but we definitely do not pay attention to our radon. I mean, how many people, I ask people when they come to the office, when was the last time you checked your radon level? People don't
Well,
I
so
mean,
tell our listeners, what is radon and why should people be checking radon levels?
so
And it is related, obviously everything that we're discussing because of cardiopulmonary connection, has some relationship, of course, to cardiovascular disease and, for microplastics and nanoplastics to end up in carotid plaques. They usually get there through inhalational route, right? That's probably the number one route where they will get through, as well as a lot of fossil fuels and plastic byproducts. They also cause endocrine disruption, and maybe that's the reason why we're seeing younger and younger breast cancer and colon cancer. So, but what is radon? Because it's another environmental concern strongly linked to lung cancer.
Absolutely. So radon gas, you probably heard about it whenever you bought a new house. They tend to actually measure the level of radon. It's naturally occurring radioactive gas. And it actually comes from, I think, the breakdown of uranium in soil and rocks.
Mm-hmm.
And generally, outdoors, there's so little radon that it's not even dangerous for you. However, radon indoors, specifically in the basements, can be highly concentrated. Actually, the house that I moved in had a high radon, but the good news is we actually have a system to evacuate the radon, and you can constantly measure it and make sure that it is at a very low level. The EPA has strict regulations, and each county, even in the people that don't think about it before they end up doing real estate evaluation, the radon level is actually required and it's measured before the sale is complete. So even if it's high,
And so this system, it sits in a basement to evacuate
correct, to
radon.
evacuate
And
radon out.
if let's say the house does not have a basement, because there are some areas in the United States where houses actually don't have a basement for a
Correct.
variety of reasons, is radon a concern if there is no basement?
Even if there is no basement, I always try to tell patients to measure the level in closed environments that might be at a lower level, even if it's not underground, because it's really, the danger is in the contained space. And especially if you end up having bedrooms in areas that are at low level, even if it's wide open and it's not a basement and it's toward the outside, it's an open basement. If you want, and the house is sitting above, you still want to be able to actually measure it. If you have a good aeration system, chances are it's very low. But the reason why I insist on this, it's because it is still the second leading cause of lung cancer in our country. It's something that is so preventable. So you have smoking and you have radon. Radon must be checked. And if for anything, if you're listening, please go. It's very simple. Just order it online. Go get the kit, put it downstairs, send it
So
in.
there is a kit that one can order online, or can one, for example, call the Department of Health of their
or the
county?
ALA. Yep. The ALA has a link there that actually clearly shows you where to get the radon measurement device. And then you send it in and then you contact, there is radon organization, radon societies, radon evacuation society. They come in, they install it, and the evacuation is done. And you can read the level every day. You can go downstairs and read the level.
Interesting. So we talked about smoking. We talked about the rise of lung cancer in
Correct.
non-smokers. Are we seeing this troubling trend of younger people coming down with lung cancer who have never smoked or, and don't really have any expected exposures, perhaps maybe some radon exposure, but are we seeing any particular type of cancers, or are we just seeing garden variety, typical adenocarcinoma of the lung?
So the majority of them are adenocarcinomas, not necessarily squamous cell or small cell. Small cell was really a smoker's disease. We have come a long way as far as therapies. Usually small cell used to be a 6 month or a few months and they're gone. I have people with a stage 3A that ended up getting the new therapies and even the immunotherapies. It's amazing. They're still going strong. So, but it's definitely not a small cell carcinoma. These patients end up developing, if it is genetic based, an EGFR or ALK gene, if that's what they have, they end up having an adenocarcinoma that is and can be treatable. Because now the way I explain it is a lock and key. So if you can imagine cancers being locks and keys as our drugs to actually resolve them, what end up happening is we had tons of locks and almost hardly any keys. We just used the hammer to smash the locks.
Yeah,
Now we
that's
have tons of
chemotherapy.
keys. And now we have keys, immunotherapies, targeted therapies that sometimes even match 100% that lock, and it just shuts it down. So what I would strongly recommend, if God forbid there is a carcinoma diagnosis, is to absolutely push for genetic testing. Next gen sequencing and genetic testing of the tumor is a must before starting therapy. There are still pockets in the country that don't necessarily test for genetics, which is insane. But you cannot treat nowadays without genetic testing. It would be
So it's
criminal.
interesting because I do a lot of genetic testing, obviously, in my practice, and we do both uh, monogenic and which means looking for a single gene, looking for specific variation that is well known, and this process in the most primitive technical way is called genotyping, right? So for example, a lot of patients or a lot of adults, they'd like to understand what is their genetic profile like, how it may affect their need for a specific nutritional plan or certain supplements, or even how they may respond to medication such as statins. So this very fairly simplistic testing level genotyping could provide some insights, but it's testing for known variabilities, right?
Yeah.
And then if we go into next generation sequencing, and we're definitely going to have an episode on the genetic testing. Next
Yes.
generation sequencing is much more involved because it is not testing only for these known genetic variabilities. It's testing for other things that we may not even know about, because our DNA could have pieces where something gets inserted into it, or pieces where certain expected areas are actually deleted. And finally, we have computational methods adding all of these variabilities together. We could actually generate a polygenic risk score. And, it's fascinating because there are direct to consumer companies currently on the market, actually several of them. And they are providing people with the output with regard to those polygenic scores. They're typically using low pass next generation sequencing or just low pass sequencing, and they're doing what's called whole exome sequencing. And, exomes are just the coding portions of the DNA. So what would you say that, should somebody, let's say it's a person, maybe they're in their 30s, maybe they're in their 40s, they didn't smoke, but they have a family history of cancer. First of all, what is considered a worrisome family history is, in cardiology, we typically look at primary degree relatives, but, certainly we would listen if somebody had an uncle or an aunt or, grandparent, a cousin who potentially had early heart disease or specific types of heart disease. So what is the worrisome family history that people should be aware of with regard to lung cancer?
So lung cancer history, like I said earlier, is within the third generation. So if mom or dad, brother or sister, uncle or aunt, grandparents, and that needs to really be mentioned, if not asked. And that by itself, if there is such family history, should be really a motivator to push for a screening scan. A lot of people that have been involved in their family treatment and therapies are very conscientious and are very proactive in coming in and fighting to be able to get that CAT scan. Now,
Should
remember,
they get, do you feel that patients who are coming from families where there is lung cancer history, and family history even in cardiology is always very challenging because it doesn't technically track with anything. It is included in risk factor algorithms and models, but we haven't, for example, shown that if somebody has a family history in primary degree relative, that we are more likely to get an elevated calcium score. There is no relationship like this that's been demonstrated right now for cardiology. But does it make sense for these type of adults who are concerned with the family history of lung cancer to actually go and get genetic testing, considering that a lot of this genetic testing is now direct to consumer, and you can sort of poke around, and even with these whole exome sequencing models, they if you through a few clicks on the internet, they will connect you to some of the genetic databases, and they will spit out, you can dial in lung cancer or breast cancer or what have you, and they'll tell you, do you have this variance or not? So should people be doing it?
So honestly, we are not at the level where, like, for example, for breast cancer, where if you have a BRCA gene, you are at a higher risk and you need to be proactive about it. With regards to lung cancer, I mean, there's a strong family history with the EGFR and the ALK, definitely. But from there to start getting low dose CTs or to actually do genetic testing, there is really nothing out there that will be able to tell you, yes, you are at risk, you have it. However, first of all, the low dose CT should not really be done unless you have a cumulative risk factors. Suppose you're a chef and you deep fry every single day and you don't have a good ventilation, or you have a secondhand smoke exposure and you have a mother or father or even a brother that ended up having lung cancer. I had a patient whose two sisters ended up having lung cancer. Father had lung cancer, definitely compelled. She had no risk history, no risk factor other than the family history. I was very compelled to do it. What we were facing, though, is she ended up having lung nodules, but they were sub-centimeter lung nodules. So what do you do then? You repeat the scan every year, but then you have to weigh the risks and benefits of undergoing that scan because of the radiation that you're exposing her to. So to try to figure out what to do, which was interesting, in addition to calculating the pre-test probability of that lesion. In her case, she had a 7 millimeter nodule. 7 millimeter is really a cutoff where you couldn't use a PET scan. PET scan is a scan that looks at the body, and they inject a sugar tag. It goes in and it tends to light up if, God forbid, there's a high concentration of sugar in that lesion. So the 7 millimeter lesion,
Which would be consistent with cancer, right? So if something picks up that sugar, it's glucose that gets picked up by cancer cells, and we also use a PET scan in cardiology. Obviously, it's a similar, but it gets heart picks it up because a sick heart actually prefers sugar. It's an easier energy fuel versus free fatty acids that heart typically uses in a healthy state. So, all right, so would that be a way for a patient to go then, to kind of go into more advanced imaging, even though, fairly small nodules might not be necessarily bad?
So the PET scan lights up in cancer, but also in inflammation and infection. But to answer your question, 7 millimeter is way too small and might not be picked up on PET CT. And that's why in her case, we were facing, do we repeat the scan within 3 months or 6 months or 8 months? Or do we biopsy it? It's very small. Or what do we do about this? And so what we tend to do is we use the Mayo Clinic calculating pretest probability score that will allow us to calculate the risk factor, the probability that this lesion is cancerous or not.
It's cancerous.
It's done online. It's the MD calculator, and anybody can do it. You plug in the age, you plug in the size of the lesion, the location of the lesion. If the location is at the top, chances are it's more likely to be cancerous than not. You plug in whether or not that person had cancer within the 5 years or not. Obviously, if they had, high risk. And then you plug in if you had a PET scan or not. And that calculates a certain probability. And of course, whether smokers or not. And that tells you whether or not you will be at risk of having that lesion being cancerous. The beauty that we have nowadays is that we do have what we call a notify test, which is a blood test that looks at these genetic sequencing to figure out whether or not the genes that are present in those cells correlate with a higher risk. But this blood test does not tell you for a fact. It just tells you in conjunction with all the other information whether this patient has a higher risk or definitely a lower risk to develop lung carcinoma. And this blood test has been actually implemented in all the pathways now in the lung nodule clinics that we have. Patients found to have a lung nodule clinic, they end up, if they're large enough, they do a PET scan. If it's not large enough, we don't do the PET scan, and then we automatically test the notify, which is the blood test for anything that's 7-8 millimeter up to 30 millimeter, no more than that. And then we use the pre-test probability with the Mayo Clinic plus the notify scoring. You combine them and figure out if they are lower risk, so you can relax, or if they are higher risk, then you proceed aggressively, if not doing the biopsy, resecting the lesion.
So that would be done, but if a person does not have a nodule, then you really are not using these algorithms, right? So something has to be found for even to get this level of estimates, right? To get this level of personalization. If it's just a fairly young person and they don't have any specific lung findings, but they have a family history of lung cancer, sounds like the best strategy for them is to advocate for themselves to get a low dose CT as a screening tool, right? Because they're not going to be somebody who qualifies for these additional tests if there are no detectable lung nodules. Is that correct?
Absolutely. And that's the battle with the insurance company. But yes, and keep in mind, majority of us have some nodules. I mean, the majority of the nodules that are found are benign. That's the reality of it. You can have nodules if you lived out in Midwest and ended up having valley fever. It's going to end up being spots all over your body. You might end up having lung nodules if you have what we call bronchiectasis, where you produce like the smoker's cough or you hack away. Remember those little balloons we talked about at the beginning? They can tend to trap mucus. That mucus will show up as dots on the CAT scan, and the dots are what we call nodules. So nodules are not necessarily meaning or equal to cancer. It just means that there's something inside those trees, whether at the level of the balloons or those little pockets or in between the branches and the airways. And depend on the size, the location, you ought to really have it investigated. And I also say, when you get a CAT scan, chances are, if you look at the CAT scan and you have tons of little teeny tiny nodule, probably it's not cancerous. I would rather a patient coming in with tons of little tiny than a patient coming in with one single 10 millimeter lesion, because that's more concerning.
Right. That's more concerning. So let me ask you, as we approach, it's a very interesting discussion. And I think I learned a ton, certainly the understanding that women were more susceptible to lung cancer due to exposure to cooking fumes. That's just absolutely mind-boggling here. So I'm curious, though, is that there is some interest, or maybe a lot of interest, depending on who you speak with, in direct to consumer whole body MRI investigations, right? There are quite a few companies that, have it on their website. And I had some of my colleagues ask me about it. I personally didn't have one, at least not yet. And, some patients have an interest in it and it's heavily advertised. So would a person who goes and gets a whole body MRI be someone who potentially could be identified with early stage lung cancers? Are they visible, or is it really that low dose CT that should be done?
So am I a big fan of the whole body MRIs? I don't know. The jury is still out there, because the question is, you not only need to do it, but then you get into chasing maybe your tail because maybe something is there and you don't necessarily need to worry about it.
Right.
And I mean, as physicians, we might have a better grasp on what we're looking at. But for the general population, I couldn't even imagine reading a report with all these abnormalities and which one do you go after first? And here you had no issues and now you're like, oh my God.
Well, but it's interesting because recently I got a promotional, I guess, email from one of the companies that does it. And they are now offering a CT because they're also going to be scanning, obviously, for calcium score and doing a CT angio. And so between the two imaging modalities, obviously, if there is a tiny, small place where either a nodule or potentially a cancerous nodule, one could identify. But, I'm sure a lot of physicians will feel the way that you feel, that this is image overutilization and, waste of resources. And certainly it's not something that would be reimbursable by insurance. It's completely out of pocket for adults or patients who wish to be very proactive in how they approach their health. So, Nina, closing statements, what is your message to people who are listening to us? My podcast is Own Your Heart Health, and that obviously goes into Own Your Health in general. What should people look for? And, we spoke obviously about exposures to fumes, radon. What is the kind of number one approach to keeping their lungs healthy and, hopefully at least somewhat protected against everything that we've discussed so that their chance of developing lung cancer is lowered?
My biggest message is to watch what you breathe. Honestly.
Watch what you eat, but you have to watch what you breathe. I like that. Watch
Watch
what you breathe.
First of all, if you see it, chances it's going to get deposited in your lung. And
Okay.
we tend, if you don't, and be much more aware of what you cannot see and breathe in. Definitely act to stop breathing in too much of the product that we have in the homes. It's okay to not smell like the Febreze of the world and the candles around. Clean up your indoor, your safe space, your home, specifically your bedroom. Try not to burn incense or burn things that tends to actually, that's your safe haven. You spend 6 to 8 hours in that bedroom breathing in and out in a closed environment, all these products. So get rid of the softeners in the clothes. You are steaming these chemical products just to make it smell better. Get rid of that. Don't smell it. It's sticky. It's yucky, 120 degrees inside the dryer. And then you breathe it in, you put it in your sheets. Try to get rid of that. Microplastics. Take a look at the amount of plastics in everything that you're wearing and you're sleeping in. You'll be surprised how much plastics is in there. Microplastic is definitely a reality nowadays, and it is going to become at the forefront of multiple healthcare concern. And definitely, last but not least, this message is for women. It's not really a coincidence that women are suffering more from lung carcinoma than others. Because, and I tell this to my staff, to everybody that I actually work with, when you go inside your bathroom and take a look around, how many aerosolized cans do you have in there?
Right.
Between the dry shampoo, the makeup, the hairspray, it's insanity. The sunscreen spray, and slowly,
I use zero sprays on my body or in my house. There is zero sprays. There is no sprays. There is no cooking sprays. There is no personal sprays, zero sprays. And I have to tell you, it's amazing because currently there is some testing available, which is, I'm not going to say it's experimental, but it's certainly a little bit, in the gray area of functional medicine. We could test the toxic exposures through urine, through looking at certain specific metabolites and kind of backtrack those to where is this exposure coming from. And I went into that testing first for myself, and then I expanded it to the patients that work with us. And I have to say that so far has been the scariest test that I had ever seen, because I am yet to find a person who actually doesn't have anything of concern. And, so either the test is way too sensitive, which could happen because it's a fairly new test, or we truly are just so bombarded by toxic exposures that we have to every single day take active steps to reduce it, because we don't want microplastics in our arteries. We don't want, surfactant in those alveoli and those grapes trapping, fumes with all of the carcinogenic compounds plus microplastics. So we want to clean up. So watch your breath. I like that. Nina, It's been a delight. Thank you.
Same here. Thank you so much for having me. It's been a pleasure.
You got it. Take care. Bye-bye. Hi to all professionals listening to us today. If you're thinking of launching a cardiometabolic or integrative cardiology program in your practice, we can help. At the Holistic Heart Centers, we help docs in practice to expand into hybrid or concierge services. Head out to the show notes and click on the application link. Your intro call is entirely free. Ready to schedule a practice review? Use code DOC10 for 10% off our Practice Power Hour 16 minutes coaching session. The link is in the show notes. Thank you for tuning in to Own Your Heart Health with Dr. Regina Druz. This podcast is powered by Holistic Heart Centers. If you enjoyed the show, please rate and review us on your favorite podcast platform. To learn more about our services, visit holisticheartcenters.com and subscribe to our YouTube channel. The link is in the show notes. See you next week.